Steve Dungy here, a specialist at Royal Perth Hospital, and I've been asked to give a 5 on Friday talk on the subject of atypical presentations of sepsis. I've certainly had the experience on a number of stages of my career where I come to work early in the morning for an 8 a.m. handover and see a whole flurry of activity occurring in the resus area of my emergency department. And the story is that there's an elderly person with known septic infection who hasn't been well all night but has collapsed all of a sudden just prior to handover. And in fact, when you look at their observation chart, you see a gradual slide and a sudden cardiovascular collapse. That particular experience of having somebody collapse all of a sudden is repeated in thousands of hospitals around the world every day of the week. But the fact is that something big happened in medicine in 2001. There was a really shaping paper published with a very unexciting title, Early Goal-Directed Therapy in the Treatment of Severe Sepsis and Septic Shock. It's known by everybody in critical care circles as the Rivers paper. And a group of researchers basically studied the subject of severe sepsis. What they demonstrated in the paper was that it's common. In fact, deaths from severe sepsis are the same as deaths from ischemic heart disease in our community. It's common, it's bad, and that the really big point was there's things you can do early on in the course of the illness that will change the outcome. A lot of it's common sense. Give fluids, give inotropic support, give antibiotics, give antibiotics, give antibiotics. It's worth repeating. Every hour's delay will result in a 5 to 10% increase in mortality rate for patients with severe sepsis. And source control. If there's a source of pus somewhere, let it out. That paper changed the way that we look after patients with sepsis. But part of our challenge is that not every patient turns up looking like they're septic. It's fine when you get a patient who's febrile, 39.5, tacky, flushed, sweating, high pulse rate, low blood pressure. My old mum could say they've got sepsis. But there's a subset of patients in our community whose immune response is a little bit different, who don't show the classic signs. And the real take-home messages from the talk today is giving you a list of who those patients are and explaining how they might look. Who are these patients? Well, the biggest group is the elderly. Their immune response is not that feisty, and their cardiovascular response isn't necessarily either. 60 to 70% of the deaths we're going to see in this group of patients is in the elderly. Patients on chemotherapy, their immune system is very significantly suppressed, and particularly about day 10 after a chemotherapy course, the white cells in their system are at their lowest ebb, and they're at high risk of getting life-threatening infections. There's a lot of people in our community who have an immune cause to their illness. They've got Crohn's disease or rheumatoid arthritis, and they're on steroids or another immunomodulating drug, and their immune system's not normal. We have patients who have had organ transplants and are on immune suppressants, patients with HIV, and the last group are people who are on a beta blocker. And what that means is they're not going to get the tachycardia that you might expect. So those are the people who are at risk of having an atypical presentation. What kind of presentations might they have? The most common is they're just sleepy, sometimes comatose. And that's the way the sepsis manifests itself. For the elderly, often the story is there's been a functional change. So Nana all of a sudden is starting to fall over, and she doesn't tell you she's got a bladder infection or a chest infection, but that's how it manifests. Unstable blood sugars is another one. It may be vomiting or a loss of appetite, and it can be something as simple as, I don't feel right. The message to take home from this talk is that sepsis is bad. It's a big cause of death. There are many things that we can do early that make a big difference, and one of the biggest things is giving antibiotics early. And there are patients within our community whose immune system is not normal. The elderly is the biggest group, but chemotherapy agents, patients on immunomodulators or beta blockers, transplant patients or patients with HIV, for a paramedic, giving an early heads up will make an enormous difference. Somebody who comes in and says, I've just picked up a young chemo patient who's 10 days post the start, who's got a temperature of 38.5, I can promise you will make an enormous difference to that patient's reception. Those patients need to be brought in early. And if you're talking to a triage nurse who doesn't seem to get it, ask to speak to the senior doctor, because it may be the difference between life and death. A much harder group to deal with are the elderly. It can be really frustrating as a paramedic to pick up a patient who you're pretty certain has sepsis as a potential cause and failing to gain any traction. And there's multiple reasons for that. But again, we need to know if you think a patient has sepsis as a potential cause. The other groups that we talked about, organ transplant patients or HIV patients, again, same deal. It's really important that you make the point and you stress the point. I am concerned about significant sepsis in this patient. That's the end of the talk, and the best of luck in your next struggle with the triage staff at the emergency department and maybe the senior doctors as well, but you can make a big difference. Thank you.